Well, good morning, everybody, and what a joy and privilege it is to be here with you guys as the future of the profession. And thank you to the Chartered Society for inviting me. When I was thinking about what I'd like to talk to you about today, communication skills came out really strongly. I'm a clinical academic in Southampton. I think I've got the best job in the world because I'm involved in teaching at the university. I also do research around communication, and I still get to practice as a consultant physio at Southampton General Hospital in musculoskeletal as well. So it's a bit of a strange title. Talk isn't cheap, it's priceless. And it was based on, there was a phrase you've probably heard called talk is cheap, which was around from the early 19th century. And it reminds us that really actions speak louder than words. Just talking isn't enough. But I want to share with you in the time we've got together why your communication skills are the most important thing that you will use in your training and for the rest of your career. They are so important, they are actually priceless. So, without any further ado, let's have a look. So what I'm going to talk about is what makes a good consultation, some person-focused approaches, first impressions and small talk and what to be wary of. And then I just want to share with you a little bit about how society is changing. And it's not just how we communicate with patients, it's also with our colleagues as well. And then some current work we're doing on minimising language, which is great fun, and some take-home messages. So, what is a good consultation? We've known since 2006 from Laram's work, it's 5 things. Patients want to be taken seriously. They want an understandable explanation of what's going on. They want patient-centred care, reassurance, and also being told what can be done. And if any of you, can think about health consultations that you might have had, I'm sure those things resonate with you all as well. So we've been researching communication. When I look back, it's about 17 years now. And one of our early studies was this mixed methods program of 3 studies. The first was a cross-sectional study, observational. The second was a longitudinal, looking at how relationships develop over time. And it was all geared towards a randomized controlled trial. And so the first thing we did was map the communication that goes on during consultations between physiotherapists and patients with low back pain. And when I look back, we published this back in 2013. But you can see there just some key headlines to help set this in context. These were 40-minute appointments, and you can see there on average they were 38 minutes, 59 seconds. Physios, we talked for half the length of the consultation. To be honest, I'm surprised it wasn't more in some cases. Patients talked for a third, but what was really noticeable was 12.5% of those initial back pain consultations were advice giving. It's something we do in spadefuls. We also found something that maybe I perhaps hadn't thought about before was how much physios interrupt, and that increases as you get more senior in the profession. So those of you that are a little further down the line, you might be thinking about that too. So when we think about patient-centred or person-focused care, what do we really mean by this? And I had the pleasure of working with Nathan Hutting, JP Canero, Martin Ongwen and Mitzi Matchek, and we were really looking at 4 things. It's about establishing a meaningful connection, shared decision-making, self-management support, which is becoming more important than ever, and how to tailor our communication to make it person-focused and individual. And if you want to read more, we've got a couple of papers in musculoskeletal science and practice. Now, what is a meaningful relationship? And we think about our communication, and it's really 3 things. It's what we say, it's how we say it, and the non-verbal. So what we say starts with the very first time we meet and greet a patient. How do we do that? What do we say? How do we introduce ourselves? Then there's the how do we say it, the prosodic features, and that's things like the tone, the pitch, the volume, the rhythm. And the best example I can give you, if I use the words, if you said, how are you? And I said, I'm fine, I might say, I'm fine. I might say, I'm fine. I might say, I'm fine. Now, they were the same 2 words, but really different impression it leaves you with, and that is what prosody or prosodic features are all about. And then, perhaps the most important bit is the non-verbal, the smile, the head nodding, the eye gaze. And of course, what is so powerful as physiotherapists is touch. We have such a privilege to get to know our patients well. So it's all about showing an interest, whether you're doing this online with a patient or whether you're there in the room with them. And I think a really powerful thing for you to think about is your patients might not remember what you said to them, but they will remember how you made them feel. That is so important. They may not remember what you said, but they will remember how you made them feel. So, those relationships, my goodness me, they start quickly. Do you know, from the literature, it says as little as 39 milliseconds is all it takes for you to make an impression of each other, and you only get one chance to make a first impression. 39 milliseconds. So while you're thinking about the patient out there in the waiting room or on the ward, they're also making decisions about you. So next we need to think about small talk. Now that's been described as conversation about things that are not important, often between people who don't know each other well. It is the sort of thing when somebody says, you know, how are you? And it can really get in the way of a meaningful conversation. And I wanted to share with you one of the findings from our research. And what had happened was there was some building work being done in the hospital, as there always is, and a physio had gone out to the waiting room and invited a patient to come into a musculoskeletal outpatient treatment area. And as they walked down the corridor, I heard the physio say, "How are you today?" And the patient replied, "Well, that's a bloody stupid question, because if I was all right, I wouldn't be here." Now, they had lost it before they'd even got into the room, and the physio did a cracking job of trying to salvage that for the next 40 minutes. And a few days later, I had gone to see the patient at home, and I said to him, "Tell me about your first appointment." Now, he was really interesting. He had a background in customer services and was studying a PhD in philosophy. And he said, "It didn't start off well. You see, when people say to me, 'How are you?' I hate it when people say that, because that's like to me saying, 'I don't really care how you are actually, but I'm going to ask out of politeness.' It's one of those sort of offhand statements which I try and coach other people not to say, because I felt like saying, 'If you want to know, I'll tell you, but you don't really want to know.'" He was in full flow at this point and carried on. It's one of those statements people should avoid. You're better off saying, "You look crap." You know what I mean? At least you're making a statement. 3 little words. How are you? So if we go back to our definition that small talk's about things that are not important, I'd encourage you to think about that. 3 little words destroyed that consultation. So we're thinking about communication skills, and I want to think about society is changing, and I don't know if you've come across it, but the Mind the Gap report is a fascinating read. It was published in 2015 from Health Education England, and it was a piece of work that was done around trying to encourage nurses and midwives to stay in the profession. And it was done at Birmingham and Solihull. It was part of the Every Student Counts project. And what they did was they sent out surveys to 1,432 final year and newly qualified nurses and midwives. They had 45 nurses in focus groups. They had 75 nurses writing reports and 600 people in an interactive event. And they looked at what was different about communication in these 4 groups of people. You've probably heard the baby boomers, the generation XYZ, and so on. But it's really interesting when you start to drill down. For any baby boomers in the room who are ambitious and question everything, motivated, hardworking, may or may not play such a big part in technology, but their development relies on support, feedback, and status. So you might find yourselves, those of you when you're out on placement, you might be being supervised by somebody who was born in between 1946 and 64. Or it might be Generation X, those of us that are in that group from 1965 to 79. They like structure and direction. They see education as a means, it has to be meaningful. And they are techno-literate, but clearly not in the same way that our future generations are. But this is an interesting one, isn't it? Tell me what to do, but not how to do it. So again, you might be working with colleagues in the department or even supervised by people from that generation. Then we go on to Generation Y. They expect support to achieve. They're ambitious, high career expectations, great, frequent recognition and feedback, and they need mentoring, coaching, and reassurance. So again, their needs, you can see, are starting to be quite different from some of the earlier generations. And by the time we get to Generation Z, self-directed, up to date with technology and leave other generations behind. Absolutely, my daughter's in that group, and I would definitely say she's way ahead of me. Getting frustrated at the manual methods of working. Don't force me to fit into a traditional environment. And I expect to be informed, but you must listen and acknowledge my response. So can you see there's quite a shift in those four groups? And I know they are generalizations, but I hope you can see some truth in all of that. And it helps us to think when we're there with patients, supervisors, colleagues, friends, do we tailor our communication, bearing in mind those thoughts? So that's a little something to challenge you. So, moving on. The patient's agenda. What we need to think about, how on earth do we know what that is unless we ask? It may be they've come for a diagnosis, second opinion. They might be comparing you to Dr. Google. They may just be looking for an investigation or reassurance, or they actually want some treatment. So we need to be clear in our communication and think about how we phrase our questions. And if you don't already use them, I encourage you to think about TED questions. Tell me, explain to me, describe to me. And if you use those questions, you end up asking fewer questions, but get a lot more depth out of your history taking. So, can you tell me how this started? Can you explain to me how this is affecting your life? Can you describe how this makes you feel? And what we need to be careful of is when we reply back to patients, there's always that encouragement to show you've been listening, and we might paraphrase. We need to be careful of what Carter talks about as being a professional ventriloquist. And I've heard people sometimes come back from motivational interview courses. Patient will say something, and the physio will rephrase it going, so I've just heard da-da-da-da-da-da. And patients can sometimes get quite cross with that and say, well, I've just told you that. So you have to be really skilled in how you do that. Now, I mentioned earlier about the dreaded interruptions. In our work, we noticed this was going on a lot. And looking at the literature, there are two different sorts of interruption. The first is an overlap, where there's an error projecting when somebody's going to finish speaking. You just sort of dive in and nip the end of their sentence. That's different to an interruption, which is a full-blown when you cut through about something completely different. And in the literature, if you ask a patient about why they've come to physiotherapy, the literature suggests it takes 92 seconds for somebody to explain their presentation. It's one of the only occasions that they get the opportunity to take the floor. Now, we found in our study that the senior clinicians interrupted 7.6% compared to our more recently qualified colleagues at 2.6%. Nobody finished had 92 seconds to explain, and in 60% of that initial question about whether at physio or their knee pain or back pain or whatever it was, the questions were interrupted. So we looked at 15,500 turns, and I was really interested. You can see there that the physio's in blue and the patients are in red. Look at the number of overlaps from patients. They are desperate for you to hear them. And clinicians, we were 7 times more likely to cut across and interrupt. And if you want to read more about that, it's in the Journal of Communication in Healthcare. But just remember, the letters in listen also spell silent. That's something to ponder. Okay, so if you're able to ever get the chance to record your consultations, again, obviously with patient permission, it's fantastic because you can look at your shared decision making, you can look at so many things. But one of the things is this, what I've called minimizing phrases. It's things like just, quick, pop, only, these little phrases we use. And I first got interested in this when I heard a rheumatologist talking, and in their department they were doing the annual satisfaction survey, and everyone was thinking, oh God, the one guy is going to be brilliant, he's going to make us all look rubbish. And when the results came in, they were all very much of a muchness. And he had a linguist working with him who said, actually, I've noticed at the end of your history taking, you say to the patient, do you just want to pop the shirt off, we'll have a quick look at your neck, and blah, blah. And she said, these patients have waited months to see you. Nobody wants a just, a quick, a pop. So he changed nothing about his practice except at the end of history taking, he said, if you'd like to take your shirt off, we'll have a really thorough look at your neck. Didn't do anything different to what he was doing before. And anecdotally, when those satisfaction scores came in, they were so much higher. So I'm working at the moment with a linguist, and we've got some funding from the Musculoskeletal Association of Chartered Physios and from Elsevier, and we are looking at what is going on with this minimising language. And this is hot off the press. This is from 2 weeks ago. We've just pressed the button. My God, the word just appears 54 times in an average consultation from the physios, and patients it's 23 times. Now, I'm not suggesting it's always a bad thing, but it's really important to be aware of what these little words do. It can be used very empathically. For example, we've got a lovely situation of mirroring when the physio's palpating and she said, how's that? And the patient says, oh, a bit tender. Physio, oh, just a bit tender when I'm pressing it, yeah. So again, just using it to kind of align, and that felt really quite positive. But we found some really interesting patterns that we're delving down into more now, where you can see a story of the patients escalating their symptoms. I've got 3 examples for you. So this was from our longitudinal study where the patients were coming back in, and this started off, I've had 3-4 disturbed nights in the last 3 weeks, which is a lot better. So this consultation started with the patient saying they were a lot better. Physio, were you woken up? And I've underlined just once or twice because that's the damage. Yes, okay, but. Now, whenever you hear the word but, you know you're in interactional difficulties. But I still have problems moving in bed, when you turn over. I can't lie on my side for very long. I'm having to lie flat on my back as I normally sleep on my side, and I'm finding that very difficult. So if you look at those escalations, they started off, they were a lot better, but I still have problems. I can't lie on my side. I'm finding that very difficult. Can you see there's a pattern here, and it's getting stronger? It also happened, we've got loads of examples, but here's one where there was a straight leg raise test going on. Physio raises the leg and says, well, a bit tight behind there. Patient corrects them. It's very tight behind there. I could really feel it stretching. Physio minimises. I know you're a little bit stiff in your back. I can feel it as well. You're a little bit stiff, don't you? Patient escalates. I am very stiff. And then they escalate again, stiff as an old board. So can you see, again, the patient is pushing back with it. You're not listening to me. The more the physio minimises, the more the patient escalates. Here's another one on palpation. That's lovely. I know it's going to be a bit tender. Is that tender there? And the patient says, yeah. And then they just recheck some flexion. Look what the patient says. Oh, that's agony. Just doing that. So again, we've got this pattern of double escalation. And we're just going to be looking at all the different sorts linguistically, and look forward to publishing that next year. So next bit that I want you to think about is the importance of goal setting. And this is really helpful, especially for people with complex needs. And if you haven't seen it, I really recommend this paper by Vermont and Elwin and colleagues from 2018. And it talks about a 3-level model of goal setting. Now, a lot of patients come in for the first level of goals, which is about symptom or disease specific. I want to get rid of my pain, I want to X, Y, and Z. They may also set functional goals, so it might be using a keyboard or climbing the stairs or whatever it is. Or they can set goals that are based on their values, hopes, and priorities in life. And what Vermont calls this is fundamental goals, and suggests that we all start with those and find out what really matters to the person. And the best example I can give you, I had a patient about 3 weeks ago now in clinic who came in with jaw pain and stiffness, trismus. And when I asked her what really mattered to her, I was a bit surprised at the answer. She hadn't seen her family for 11 years in Pakistan, and when I drilled into what all that was about, it was because she had fibromyalgia and couldn't get on an aeroplane. And so she'd come in with jaw pain, and here we were looking at ways that can we get her to the point where she can get on a plane in 2025 and go and see her family. Another thing that's really useful for when you work yourselves with students in future, but also with patients, is the GROW model, if you haven't seen it, by John Wetmore. It's a model that we use in coaching, and it's really nice. It just stands for goal, reality, options, and will. So when you're talking with patients, this really helps them to own what's going on. The goal, what do you want to achieve? That's the first thing, to make sure that you're helping them work towards something that really matters to them. What's the reality? Where are you now? Then options, what options do you have? And then after you've heard that and discussed it, the will is, what will you do next? And so it's a really nice progression that just walks you through that situation where you're trying to help with goal setting, particularly when you're quite short of time. So as we bring this together, because I'd like to have some questions from you, here's some take-home messages. Your talk has the potential to impact every single patient you see for the rest of your career. It is the most important skill that you have, and that's why it is absolutely priceless. So we need to do it well, and my real pledge to you is, please will you invest as much time in developing and furthering the skills you already have as you do all the other clinical skills. So often when we qualify, people are busy thinking about the clinical skills all the time and just assume that the communication is going to happen, but we can get it even better, all of us, than it currently is. So take care with that small and minimising talk and hear yourself. I'll be in your head next time you go, just quick, only pop. We hear it all the time. Have a go at your TED questions. Tell me, explain to me, describe to me. And if you want to build some confidence, try it out on friends and family. It's hilarious. You can find out all sorts of things, and it will give you the skills to delve a little bit deeper and save you some time in your consultations, because you will get that depth without having to sit there thinking, what do I ask next? Think about those goals, fundamental goals. You've got your symptom specific, you've got your function, but have a go at some fundamental goals. They are more tricky, but really, really valuable. As I said to you at the beginning, every patient may not remember what you said, but they will remember how you made them feel. And isn't that a privilege as a physiotherapist? It is one of the many wonderful things about this profession. If you want to read more, we wrote some of it in the chapter 2 of Petty's musculoskeletal examination and assessment, and I think it's actually one of the sample chapters online, so have a look. And what I hope is this session has given you something to really think about, that what you have in your grasp is utterly priceless. So invest more time in developing your communication skills. I hope that when you're out on placement, something will change as you think about some of the things that we've said. And I wish you all the very best as you join this absolutely incredible profession. Thank you very much. I think we've got an exciting box to fling around, haven't we, Iona? Marvellous. So if you want to have a go at catching it and ask a question, please fire away. Let's see how good our skills are at catching. Anybody got a question? Yes, thank you. Oh. Yes, fabulous. We've got a question here. Yeah.
Should we try and have it?
Oh, definitely. Come on, let's have a look. Well done.
Do you have any concerns if you've got a patient, you're having an interaction with them and you're talking about saying this might be a bit painful, or yeah, I understand that's a bit sore. Do you worry about if you don't use that minimizing language, you might have a nocebo effect? So if you're saying to a patient, like, I know this is going to be very sore, you're already preempting for them that this is going to be, and you're kind of, to an extent, enabling that. How do you find that balance?
That's a brilliant question, thank you. It's a good one, isn't it? If you say to the patient, this might be very sore, what do you think might happen? Do you think they might tighten up or not relax? And then are you going to get where you want to with them? So again, a lot of it comes down to the choice of wording. Sore is quite an emotive word. You might want to change that to this could feel quite a strong sensation. It's what I often say to my patients. And, if it is uncomfortable, then, that does mean we are right on the spot, which can be quite a reassuring thing for some patients. But again, you can alert them to the fact that what they feel may be a discomfort. But I would probably be careful with words like sore, because again, you've got that kind of expectation. Or if you tell them it's going to be very sore, the chances are if I'm palpating or doing something, they're not going to relax and I won't feel what I'm hoping to feel anyway. But great thought, thank you. How could you throw in, Iona? Well done.
You identified that you noticed that people who had been qualified for longer were more prone to interrupting. Do you have a theory behind why that is?
Brilliant. I honestly don't know. I wonder if some of it is because they want to sort of get straight to the point, and some of it is around that pattern recognition. They may be more likely to have seen something before, so they want to kind of cut to the chase. But if you're a patient, how does that feel if you're interrupted? And we know that there's good literature that patients actually really like being treated by students, because actually you tend to have a bit more time with them, you can identify more, and it's some of those skills you perhaps haven't quite grasped, the art of, dare I say it, the art of interrupting as much as more senior colleagues. But actually when you're on the receiving end of being interrupted, it's not great. So yeah, good thought. I've got to throw it this time.
Has there been any more looking into why we interrupt, as in, is there any link between time pressures?
There hasn't been anything actually written to say that's what it is, but I'm sure that's very much a part of it. I think it's probably why also patients are so desperate to overlap, because they know you only have a finite time with them and they want to tell you kind of everything. So I think from the patient's point of view that it is very much around time, particularly if they've waited a long time to see you if it's outpatients. But also I think for the therapist, it's very much, you know you've only got a finite amount of time. If you're on the wards, you've probably got a stack of people you need to see. If you're in outpatients, they're probably sitting outside waiting for the next appointment. So time is very much of the essence, and that's why we do tend to really try and go quite quickly through that. And I think that's why it's important with things like the TEDS questions, you ask fewer questions and you can listen more. You actually get more information and don't feel quite so much under pressure. But that's something to play with on your next placements. Any other questions? Yep, we've got some at the back actually, Anna, yep. How good's the throwing to the back of the room?
Do you have any thoughts on like using language around talking about pain? Sort of I feel like using the word pain sort of like centres it, doesn't it?
Yeah.
Which maybe you don't want to do. But then sort of thought about using like discomfort. Does that risk like minimising patients' like pain experience as well? Or?
Yeah. I very much try and use the words that the patients use. And I think what taught me a great lesson early on was when I said to a patient who came in and on the referral it had said neck pain. And we were talking and I said, so, you know, how did your neck pain start? And he looked at me and he said, neck pain? I haven't got neck pain. So I said, oh, I'm so sorry. And he'd sort of indicated round here. So I said, I thought that's where your symptoms were. And he said, they are, but that's not my neck. So I'm thinking, okay, so where is your neck? And he said, it's here. So I said, so what's that? He said, that's my spine. Okay, so how long have you had spine symptoms? And, you know, trying to put it into the words of the patient. So if they've used the word pain, then I would. If they've used something else, they've got sensations or this or that, I would try and mirror that. But if they have talked about pain, if you deliberately don't mention it, then you can find yourself in a way you've minimised it. You might want to explore with them, is that actual pain? Is that more of a discomfort, an ache, a sensation? You know, what is it? And then once you've sort of agreed on that, does that ache changed? Or I use a lot of scoring. You know, if I was looking at a patient's movement, I would say at the start, you know, as a baseline, out of 10, naught's nothing, 10's horrendous, where are we? And they'll say, you know, it's a 4 or whatever. And then I'll say, does that 4 change when we do these things? So yes, it goes up to a 5. No, it goes down to a 3. And that can be quite helpful as well. So it's a really good point, not focusing just on pain, but I think it's helpful to use the words that the patients have used.
We have a couple of questions online.
Oh, fantastic.
Actually, we've got one comment saying it's a great presentation
thank you.
that they learnt a lot and they feel strongly about some of the things that you've shared that they're going to put into practice.
Great.
But the question is, how do you communicate with someone that has a language barrier and try and get some of this across?
Absolutely. And this is where your non-verbal skills become so important. And, you know, it's absolutely essential wherever possible to try and get somebody to help as a translator. Ideally, you know, somebody, you know, outside of the family unit, but if not, a family member, to be able to communicate, to make sure that you really are getting what the patient wants to say. You know, it's amazing how much more when we are working with patients and there is a language barrier, whether that's because of they're doing it in a second, third or fourth language, or whether it's because of some sort of cognitive impairment. you do find, or, it could be any sort of hearing impairment, you will really have to think about, are you sitting right in front of the patient so they can see your lips if they've got a hearing impairment? Do you use your hand gestures well? You might have to speak a lot more slowly and simplify what you're saying. But if you really can't communicate, then it's important to think, what else or who else can help me? Because don't soldier on in a consultation if you absolutely can't understand each other in any way. So it is really tricky. And those of you that work with patients, for example, on a stroke unit and things, and in those early stages when they're perhaps having difficulty finding the right word, your body language will be really, really crucial. You want to give them time, and that is really a time to consider. Don't try and finish their sentences for them, or don't interrupt because you think you're helping, but actually that can add to the frustration. So great question. Sadly, I haven't got a perfect answer, but those are some things to try and slow down, simple words, just ask one thing at a time and get some help.
Hello.
Hello.
You've said don't necessarily start conversations with how are you? So what would you suggest is a suitable alternative?
It's important, it's a great question. It's important to do something that feels honest and genuine for you. I will often go out and say to a patient, welcome to physio, it's good to see you, come on in, as a sort of starting point. I did used to say, how are you? Or did you find us okay? Well, if you then speak to somebody, for instance, who's got ADHD, of course they found you. You're in the department. Or I've heard, some people start a consultation with, how did we get here? As in, how did we end up, this far down the line? And the patients just looked completely blank and said, I came on the bus. So you've actually made it really hard for yourself before you start. So what feels genuine to you? A welcome to the department is a nice thing. Thank you for coming in today. It's good to see you. Something like that, rather than, how are you? Because if it backfires, the thing is already difficult, isn't it? We're meeting somebody for the first time. We're trying to help them. We're trying to understand. We're trying to address their fears, all of the things that are important to them. And yet we can make it really hard for ourselves by, putting barriers in the way. So think about something that would feel genuine for you and practice it and see what happens.
We've got a couple more questions online. So the first one is, if you're multilingual and the patient either says yes to speaking in their language with you, should you carry that out?
Fantastic if you can. Awesome. Yes. Really, really great. And congratulations to any of you who are fluent in multiple languages. Use those skills. And sometimes it might be that you have a sort of bit of a hybrid language where, if both of you are better in one language, you might drop in and out and use. We have people in our department who, you hear them speaking in one language and then occasionally bits of English will creep in. And that's great. However you can best communicate with the patient. So great question and good luck.
And the second question is do you have any advice on how to reel patients back in when they go off on tangents without coming across?
Great question. And that can feel hard, can't it, if they're starting to go off into kind of other things that you think, I might come back to that. So again, you can gently wait for them to take a breath and at that point go, that's really interesting. Can I come back to that? What I just want to focus on at the moment is, and then see if you can sort of steer them through that bit. And then it may be that you signpost. Actually, can we talk about that when we've just done, particularly if you're in the middle of doing your testing, for example. It might be, can we finish this test and then we'll, sit down and discuss. So just, don't be frightened to take control of it, but do it in a way that gently steers you through. But the other thing as well is to think about, how do you signpost to the patient? If you're sitting down with a keyboard or pen and paper, whatever your traditional way of working is, sometimes patients say, particularly if it's the laptop, they tapped away and I was talking to the top of their head. We hear that all the time, don't we, from primary care. So again, sometimes scaffolding that, saying to the patient, look, I'd like to take some notes as we go, and you'll see me typing, but I just want to capture the really important things you're saying. And if you say that up front, then they're like, oh, and away you go. Whereas otherwise it looks like you're just not listening. And again, if they get to a bit that's really emotional, just stop, look at them and just wait and see what happens so that, again, you can control that. But sometimes if things are, quite difficult, we may end up with our sort of head down thinking, oh, this is difficult, I'll just keep typing. No, just give them some time. You don't have to say anything. Just look at them and see what comes from that. Thank you.